disagreements, internal tension, struggle with oneself, squabble, discord, friction, and opposition. There are many words for conflict, and there are also many reasons why conflict arises. Robert Townsend said, "A good manager doesn't try to eliminate conflict. He tries to keep it from wasting the energies of his people." This is an excellent way to explain conflict. Hi, I'm Beth, and this is my presentation on conflict analysis and nursing theory application. I chose the concept of conflict because it is something I deal with daily, even more now that I am in a leadership role. When I worked bedside full-time, I tried to stay away from conflict as much as possible because it honestly made me uncomfortable. I wasn't used to dealing with conflict because I didn't have to deal with it a lot growing up, and I used to be an A+ people pleaser. But as I've gotten older, I have become better at taking care of my own needs and have accepted the fact that conflict is all part of that process. This here is my mind map for conflict analysis. Antecedents include failed communication, personal differences, change in policy, such as procedure and environment, and structural factors such as budget. The definitions that I was able to find were from the dictionary: to come into collision or disagreement, be contradictory, at variance, or in opposition or clash, and also to fight, battle, or struggle, especially a prolonged struggle, strife, or controversy. The second definition is a disagreement within oneself or between people that causes harm or has the potential to cause harm. Third definition is a mental struggle between two or more oppositional needs, goals, or demands that arise at the same time. And then the fourth definition from the American Nursing Association is the mental struggles, which is internal, interpersonal disputes, which is external, or clashing values, goals, and communication failures among healthcare providers, patients, and families. And then the definition that I came up with myself is when one or more individuals have a disagreement regarding mutual goals, morals, or resources that may or may not have a favorable outcome. Consequences of conflict include creating an us versus them atmosphere, decline in mental health, loss of relationships, and disruption in the workplace. We witness examples of conflict model cases daily. One example that I see frequently on my unit is regarding aging parents and their children. Mrs. Parker is a 97-year-old female who was admitted to the hospital for left-sided weakness, confusion, and decreased oral intake. Imaging showed that she had had a recent stroke. Mrs. Parker had 3 children, 1 son and 2 daughters. Her son decided to keep her as a full code, stating his mother would want everything done to save her. Multiple specialty teams had talked with the son about the reality of the outcome of her situation, yet the son wanted advanced interventions taken, such as a feeding tube placed in her stomach. Mrs. Parker was taken to have the feeding tube inserted. Once downstairs, she woke up, was completely alert and oriented, knew exactly what was happening, and she stated firmly that she did not want a feeding tube inserted, so the procedure was aborted and she was returned to her room. The son was upset that the tube was not inserted. At this point, ethics and risk got involved in her care, and after a couple of weeks and multiple family meetings with all the specialty teams, Mrs. Parker's children decided to withdraw care and allow her to pass with dignity. An opposite case is Sarah is a nurse on day shift and Lauren is a nurse on night shift. Lauren has been a nurse for 8 years and Sarah is coming up on her first anniversary as a nurse. Lauren worked through COVID and is just burnt out. She is tired of always training new graduate nurses and is very vocal about that. So she does the bare minimum on most shifts, if that. Sarah received report from Lauren on 3 of her patients for her 3 shifts in a row. Each shift, there were tasks left incomplete by Lauren, adding more work to Sarah's day. Sarah did not say anything to Lauren, as she did not want to get yelled at. Instead, she kept quiet and played catch-up each shift. Doing this shift after shift can cause burnout and internal struggle. The theory of human caring was developed between 1975 and 1979. It was Dr. Watson's first attempt to bring meaning and focus to nursing as an emerging discipline and distinct health profession with its own unique values, knowledge, and practices, with its own ethic and mission to society. This theory can also be used as a moral or ethical foundation for professional nursing. Watson's theory of human caring includes 10 Caritas processes, which include sustaining humanistic, altruistic values by practice of loving kindness, compassion, and equanimity with self and others, being sensitive to self and others by cultivating own spiritual practices, beyond ego self to transpersonal presence, developing and sustaining loving, trusting, caring relationships, engaging in transpersonal teaching and learning within context of caring relationships, and allowing for expression of positive and negative feelings, authentically listening to another person's story, among others. This theory is used every day in my nursing practice with both patients and employees. Showing that I truly care helps individuals open up about how they are truly feeling. And being an active listener goes a long way as well. It allows the other individual to develop a trusting relationship when they know you are willing to listen and actually care about how they feel. Sometimes all someone needs is an open ear. And then this is my mind map for the theory of human caring. Again, it defines nursing as a humanistic, transpersonal process focused on caring, compassion, and dignity, rather than just curing an illness. It is centered on the 10 Caritas processes to promote healing, trust, and spiritual growth. There have been 3 versions of this theory so far. Again, the original one was in 1975 and 1979. And then in 2004 to 2007, Watson made some changes. And then again in 2018, she made the change to the unitary caring science. For practical application of the theory of human caring, these are the 10 Carita processes kind of shrunk down. They are embrace, inspire, trust, nurture, forgive, deepen, balance, co-create, serve, and open. Usefulness of this theory, like I said, pretty much explains what we do naturally as nurses, which is one reason I like the theory so much. It will never not be relevant to our practice or as a decent human being in general. This theory is helpful in my professional life because, again, it's what I do every day when working with both patients and my teammates. Some critiques that I was able to find in the literature is says the theory is abstract and considered philosophical complex, but can be difficult to apply its spiritual transpersonal concepts within task-oriented, high-tech clinical environments. It also lacks concrete, explicit directions for bedside nurses, making it difficult to measure. Does theory inform practice, or does practice inform theory? I think the answer to this question could go either way. We practice nursing certain ways due to theories, but If a better way is discovered while practicing, then we could alter the theory. And Watson's theory on human caring is a prime example of this. She has had multiple changes to her theory based on the evolution of nursing care. Positivist paradigm, to me, is a research philosophy that believes that objective scientific truth exists and can be measured through observation, data collection, and logic. And words that resonate with this are objective, unbiased, separate, quantitative, and statistical. I like this philosophy because it answers the answers that come from the data are supported and in reality. There is no second guessing. Some concerns that come with this philosophy are that it is so cut and dry. The researchers involved in the data collection don't think outside the box of the study and believe that science is the only source of correctness. Constructivist paradigm, to me, is individuals use their own personal experiences to create their own reality. And a few words that come to mind with this paradigm include individual, puzzle, flexible, subjective. This philosophy allows individuals to create their own path without going step by step with everyone else around them. They may get to the same answer, but in a different way, or they may come up with a completely different answer, which is also a concern I have for this philosophy. I like to know what I need to do in order to get from point A to point B, not being given free rein to see if path 1, 2, or 3 gets me where I need to go. I want to know what path gets me there before I get started. My health system recently updated our mobility assessment tool and have been focusing on reducing the number of falls hospital-wide. So the PICO question I came up with is, in patients who are deemed a high fall risk, how does hourly rounding compared to 2-hour rounding affect the number of falls within a 3-month period? A summary of how the materials thus far influences my practice. Theory influences practice, and practice influences theory. Healthcare is all about change and adapting our evidence-based practices to provide better care and outcomes for our patients. Just a reminder of how many theories go into our daily lives is a good time to take a step back and truly reflect on our daily practices and see where we can improve. Method of knowing, whether it be traditional clinical experience or trial and error, I believe there is a time and a place for each individual method. Thank you for listening. There's my references. Have a good night.